So, good morning to all. Now we start the glaucoma pre-paper session. And how many presenters are there? Can you raise your hand? Yeah. So, the first presenter is Dr. Raj Hirani. Is there? Oh, thank you. Sir, start. Good morning, sir.
Hello. May I start? So, good morning everyone. I am Dr. Raj Hirani and I'll be presenting our study titled Are Glaucomatous Eyes with Lower Baseline Corneal Hysteresis at Risk for Faster Progression? This was a study conducted in South India with Ethics Committee approval and I have no financial disclosures. So, in 2023, like every year, the American Academy of Ophthalmology brought out a comprehensive report or the ophthalmic technology assessment to evaluate the clinical utility of ophthalmic response, ocular response analyzer or ORA in the risk assessment of glaucoma progression. But what does it do? The ORA uses an air puff to indent the cornea and measure the pressure required to flatten the cornea. As the cornea returns to its resting position, a second applanation pressure or P2 is recorded on its outward movement. The difference between these two pressures, P1 and P2, is referred to as corneal hysteresis and is indicative of the corneal viscoelasticity. This corneal hysteresis value is also believed to be indicative of the global biomechanics and the lamina cribrosa stiffness, which can thereby affect the eye's susceptibility to glaucomatous damage. So, in their OTA report, they found 4 longitudinal studies on open-angle glaucoma patients, which were all from the US, and showed that lower baseline corneal hysteresis was associated with a faster VFI decline. Hence, they concluded that eyes with lower corneal hysteresis have a greater risk of glaucoma progression, and the ORA complements current glaucoma diagnostics. So, does this mean that we should all invest in an ORA? Before extrapolating their data to change our management, we decided to conduct a study to evaluate the association between the baseline corneal hysteresis and progressive visual field loss in an open-angle glaucoma population of South India. So this was a part of an ongoing prospective longitudinal study at our institute, and we included all open-angle glaucoma patients who had a baseline ORA report and 5 subsequent visual fields. Out of the 225 eyes eligible, we excluded those with poor quality ORA scans, unreliable visual fields, and ophthalmic conditions other than glaucoma. And progression was determined by the rate of change of visual field index over time, which is known as VFI slope. The effect of demographic, clinical, and baseline ORA parameters on VFI slope were analyzed using linear mixed models. So coming to our results, this slide shows the demographic and clinical data of 98 patients which were included in our study. The mean age was 61 years and the mean pre-treatment IOP was 22 millimeters of mercury. The baseline corneal hysteresis was 8.2 and the mean VFI at baseline was 75% and was 79%, and which was reduced to 75% over the 6-year follow-up. And the slope of VFI here we can see was significant. So then we looked for factors which affected the VFI slope using linear mixed models, and a univariate analysis found 2 parameters to be associated with VFI slope. These were higher pre-treatment IOP levels and baseline ORA corneal hysteresis. But further, on multivariate analysis, only the pre-treatment IOP was associated with a faster VFI decline. In our population, the corneal hysteresis baseline was not predictive of glaucoma progression. So how are our results different from the previous studies? One reason could be the ethnic and the genetic variations. For instance, a study conducted in the UK told that Asians were noted to have weaker corneas than Caucasians. Other reason could be diabetes. As we all know, India is a diabetic capital of the world, and it can significantly affect the corneal hysteresis. And finally, environmental factors like higher sunshine or UV light exposure can lead to change in the corneal biomechanics. This could potentially change our corneal stiffness externally, making it no longer representative of the scleral biomechanics and hence making corneal hysteresis unable to predict glaucoma progression in our population. So to conclude, in our South Indian population, there was no association between baseline corneal hysteresis and glaucoma progression. Only the increased baseline IOP was the major risk factor for glaucoma progression, and emphasis on obtaining IOP measurements using Goldman applanation tonometry remained the most important thing that we need to keep in mind. Thank you.
Doctor, this corneal hysteresis, is it related with myopia?
Yes, ma'am. So since myopic people have thinner corneas, so since corneal hysteresis is dependent on the scleral thickness also, it is already shown in multiple studies that myopics have lower corneal hysteresis. So the thickness, since it is low in myopics, corneal hysteresis is dependent on the refractive stage as in high myopics, yes.
So what you will do in myopic patients for the assessment of the hysteresis?
So for the measurement of corneal hysteresis, we will do the same. We will use either the ORA or the Corvis, the newer machine. But we have to take in account the scleral difference between the normal population and the myopic population, because that can significantly affect our results. So we have to take in account.
Because it will further alter.
It will alter, yes, ma'am.
If you do the surgical correction.
Yes, ma'am.
So it is also a problem.
Yes, ma'am.
Not only the glaucoma, but this is also a problem.
Yes, ma'am.
Okay, thank you. So now Ankita Singh is there.
Thank you.
The topic for today's presentation is analysis of retinal nerve fiber layer and ganglionic cell complex thickness in treatment-naive glaucoma patients. Glaucoma, it is one of the important leading causes of the blindness worldwide. However, the visual field defects are seen only when the 40% structural damage has occurred. But ever since the onset of the OCT, the quantification of RNFL and GCC assessment, they have brought some objective assessment to the glaucoma diagnosis. There is a gap in the literature which limits the structural and functional correlationship data in the treatment-naive patients. In this study, we have taken the treatment-naive patients to provide the true baseline disease profile. The aim of the study is to evaluate the retinal nerve fiber layer and ganglionic cell thickness in treatment-naive glaucoma patients and to evaluate the RNFL and ganglionic cell complex thickness along with the structural functional relationship between these parameters with the visual field loss in patients of primary glaucoma. It was an observational cross-sectional study done in the Tertiary Care Center of Western India over a duration of 18 months. This was a pilot study, hence 45 patients with 15 in the subgroup of POAG, PACG and NTG group were taken along with 50 normal subjects in the control group. Written informed consent was taken and all the newly diagnosed cases of glaucoma which met the Anderson criteria with reliable perimetry were included in the study, whereas secondary glaucoma, retinal pathology or ophthalmic or neurologic condition other than glaucoma that affected the retinal parameters were excluded from the study. These were the parameters recorded: A6 and best corrected visual acuity, IOP, gonioscopy, fundus examination. Thereafter, they were subjected to the macular and RNFL scan to analyze the ONH and RNFL protocol, and thereafter the patients were also subjected to perimetry. Based on the findings, the patients were categorized into three subgroups, into the three subgroups of POAG, PACG and NTG, and the patients with normal IOP and no disc or macular findings were included to serve as the control group. There was a male preponderance and with the older age group in the glaucoma subgroups. However, the mean visual acuity was not significantly affected. The IOP was significantly higher in the glaucoma subgroup, whereas the mean CCT was slightly lower in the glaucoma subgroup. The RNFL, the average RNFL was decreased in the glaucoma, whereas inferior RNFL showed marked thinning compared to the controls. The nasal RNFL thinning was seen in the glaucoma patients, however, it was preserved in PSEG group. Superior and temporal RNFL were reduced in all the glaucoma subtypes. Overall, the average GCC did not show any significant difference in both the groups, whereas inferior and superior GCC was significantly reduced in all subtypes. Nasal GCC thinning was seen in POAG, whereas it was preserved in PSEG. The temporal GCC thickness did not differ significantly between the glaucoma and the control groups. There was a strong association between the inferior GCC and RNFL thinning with the visual field loss. Average GCC did not show any significant correlation with the early visual field losses. The measurement of RNFL and GCC thickness using SDOCT, it has come up as a promising investigative modality to detect the early glaucomatous damages. By including the treatment-naive patients, we try to minimize the confounding effects of the anti-glaucoma medications on the study parameters. Here we investigated the spatial patterns of RNFL and GCC thinning across the glaucoma subtypes to gain insights into the potential differences in the pathophysiology of the glaucoma damage. The findings which were very peculiar in our study was that inferior and superior RNFL, they were the robust early biomarkers of the glaucoma damage. The average GCC was less sensitive compared to the focal damage seen in the GCC markers. In PSEG, there was a nasal RNFL sparing, whereas in POAG there was a widespread GCC involvement, and NTG there was a pronounced inferior GCC and RNFL loss. To conclude, our study demonstrates that there is a significance of comprehensive structural and functional assessment in the early detection and characterization of the glaucoma damaged patients. So, to formulate a baseline, the treatment-naive patients have been investigated in this study. The integration of the SDOCT and VFA provides a powerful tool for understanding the complex pathophysiology. Subtype-specific OCT patterns along with OCT-VFA integrations are essential to monitor the targeted strategies for the prevention and the management of glaucoma. These are my references. Thank you.
So, what are the factors that affecting the measurement of the RNFL thickness or GCC complex?
Ma'am, sir, in this case, the BCVA, the age of the patients, the BCVA, and along with that, if they were in any kind of medications, besides if the media clarity was compromised, if there was any signal strength which was less than 5, and if they had any retinal pathology, supposedly in ERM or optic neuritis, that could compromise the measurement of GCC.
So any surgery can intervene, any surgery can affect the measurement?
Yes, ma'am. So we have excluded all such patients who have undergone any kind of surgeries, who have any other retinal pathologies. So these were treatment-naive patients and who had no other comorbidities other than the glaucoma, primary glaucoma.
Okay. Okay, thank you.
Thank you.
So now our next presenter is here. Dr. Bhavna, absent. And another Dr. Bhavna Viran.
Dr. Bhavna Viranki is there. Dr. Bhavna Kotu, Dr. Bhavna Viranki, Dr. Sahithi Boba, okay. Dr. Ankusha Sonkar. Who all are there? I saw 5-6 hands up. Dr. Priyanka Gupta, Dr. Parmeet Singh. Parmeet Singh?
Sahithi. Which one?
A very warm good afternoon to all the esteemed faculty members. I'm Dr. Rajeshri Singh, and today I'm presenting on behalf of Dr. Parmeet Singh, who's busy with his MS final exams. Our work is a comparison of comprehensive glaucoma quality of life 16 questionnaire with the National Eye Institute Visual Function Questionnaire 25 and the Glaucoma Quality of Life 15 questionnaire to evaluate the quality of life in glaucoma patients. To begin with, glaucoma is the second leading cause of blindness. It affects every 8th individual who's aged more than 40 years of age, and the numbers are expected to rise to 111.8 million by 2040 worldwide. It is the severity and the duration of the patient's visual impairment from glaucoma which restricts their capacity for independent living and lowers their overall quality of life. Therefore, a variety of surveys and questionnaires have been developed to assess glaucoma-affected individuals' quality of life, each having their own strengths and their own limitations. As for the existing questionnaires, we have the NEI-FQ 25, we have the GQL 15, we have the Vishwanathan 10 questionnaire, and we have the COMTEL questionnaire. The NEI-FQ 25 questionnaire is not glaucoma specific. Also, it does not measure the treatment-related outcomes. GQL 15, on the other hand, though glaucoma specific, does not assess the general health quotient and the psychological aftermath of the disease. Same goes for the Vishwanathan 10 questionnaire. And the COMTEL questionnaire has only been applied for the timolol and pilocarpine. Therefore, there was a need to develop another questionnaire which measures not just the general health, but is also glaucoma specific and also measures the psychological aftermath of the disease. We therefore came up with the comprehensive glaucoma quality of life 16 questionnaire, which comprised of 8 domains and 16 questions in total. The scores were 0 being never, sometimes being 1, and always being 2. The higher the score meant the poorer quality of life and more severe disease. As for the methodology, it was a cross-sectional study which was done over the course of 2 years, involved 140 patients which were equally divided in the POAG and the PACG group. For the inclusion criteria, it involved patients who were aged more than 40 years or were of either gender and were on medical therapy. As for the exclusion criteria, patients with visually significant cataract, diabetic retinopathy, hypertensive retinopathy, ARMD, prior glaucoma, cataract surgery, and any systemic medical conditions were excluded. For the QOL questionnaire delivery, firstly, the CGQL 16 questionnaire was validated for the internal consistency, the construct validity, and the conduct validity. Each participant completed all the 3 quality of life questionnaires. The questionnaires were administered by the same interviewer on 2 visits, 1 week apart, to ensure consistency and minimal recall bias. As for the baseline parameters, the mean age was 58.47 years, with the maximum number of patients being in the 51 to 60 year category. There was slight male preponderance, with 80 patients being male and 60 female, and the patients were equally divided in the PACG and the POAG group. As for the results, the correlation coefficient rho was measured, which if -1 showed strong negative correlation, 0 being no correlation and +1 being positive correlation. We saw that for the CGQL 16 and NEIFQ 25, we saw a strong inverse correlation, whereas for the CGQL 16 versus GQL 15, we saw a strong positive correlation. The same being depicted in the graphs below. So, the NEIFQ and 25 and GQL 15 lagged in not assessing the non-visual domains, whereas the CGQL 16 included the visual, non-visual domains, including visual disability, psychological burden, and the social limitations. Also, it was the concise format of the CGQL 16 allowed for its completion in under 5 minutes. Limitations of the study, however, were that it being a single center study, the results may not be generalized. Also, the study has a limited scope because it did not include the secondary glaucoma types. To conclude, CGQL 16 is a concise, valid, and efficient patient tool for assessing quality of life in glaucoma patients. Thank you.
Dr. Rashmi, this your question is wonderful. But one thing is this all depends on the psychological and the lifestyle of the patient. Because I know when I was in Nigeria, the patients of glaucoma in Nigeria behaves in the other way.
Okay.
They are extrovert. So this questionnaire should be dealt in the detail. So, आपको चाहिए?
So, next time.
Thank you.
And next presenter, Dr. Abha Gupta is here, is coming. Thank you. आप ये देखिए और लेकिन दीवानी मेहंदी ये देखिए
इन सबको कॉल हो चुकी है वहाँ से
आ रहे हैं
कई आ रहे हैं कई नहीं आ रहे हैं
उनको कॉल करो
Good afternoon. So I'll be presenting evaluation of role of oral vitamin B12 and folate supplementation in open angle glaucoma. I have no financial disclosures. So glaucoma, as we all know, is defined as progressive optic neuropathy, and according to ICD-10, vision loss is seen in around 57.5 million individuals worldwide. So the obvious research question for me was, what are the non-IOP dependent factors in glaucoma progression, and is there any role of neuroprotective vitamins like B12 and folate in glaucoma progression? So the purpose of my study was to analyze the role of oral supplementation of vitamin B12 and folate in open angle glaucoma. It was a prospective longitudinal randomized intervention trial with a study duration of 6 months, sample size of 144 patients. Study group being divided into two, intervention and the control group, where the intervention received the normal anti-glaucoma medications with oral vitamin B12 1000 micrograms once a day and oral folate supplementation 5 mg once a day, and the control group only received the anti-glaucoma medications. The inclusion criteria was patients aged between 40 to 70 years diagnosed with open angle glaucoma, which included mild, moderate and advanced glaucoma of primary open angle glaucoma, normal tension glaucoma and pseudoexfoliative glaucoma on medical management. The data collection parameters included serum vitamin B12 levels at presentation and follow-up, serum folate levels, best corrected visual acuity, intraocular pressure by Goldman apnea tonometry, Humphreys visual field analysis of 24-2C, and optical coherence tomography assisted retinal nerve fiber layer and ganglion cell analysis. So coming on to the results, on the demographic data, as we can see, the maximum patients belong to the 60 to 69 years of age group, with a slight male preponderance in both intervention and the control group, and majority of the patients in the study group were vegetarian by dietary preferences. Coming on to the distribution of the diagnosis, maximum patients belong to the group of primary open angle glaucoma, and on severity scale, maximum belong to the group of mild severity in glaucoma. Coming on to the retinal nerve fiber layer analysis, as we can see, there is a loss of retinal nerve fiber layer in both intervention and the control group. However, the rate of loss of retinal nerve fiber layer is more in the control group as compared to the intervention group. Similar results were seen in ganglion cell analysis, where the rate of loss of ganglion cell layer was more in the control group as compared to the intervention group. The change in serum levels was as predicted, showed a rise in serum levels of B12 and folate in the intervention group. So coming on to the discussion, so the overall change in retinal nerve fiber layer over in time, because between the two groups follow-up showed more retinal nerve fiber loss in the control group. So there were multiple studies where I tried to study, is there any relevance of giving B12 supplementation? So I could find various studies that have shown that low serum vitamin B12 levels have shown lower retinal nerve fiber layer thickness in patients. However, there was no study that could see the effect of oral supplementation of these vitamins over progressive groups. Coming on to the ganglion cell analysis, the intergroup analysis between the group did show significant change in ganglion cell analysis at baseline and follow-up. In our study, the change in ganglion cell analysis in the intervention group was 1.74 microns over a period of 6 months, and in control group it was 2.24 microns over a period of 6 months. And there was no study in literature that could tell us the association between the serum levels of vitamin B12 and the ganglion cell layer thickness. So yes, we agree our study had a few caveats. So there was no long-term data available as to what is the safer duration of supplementation of these oral vitamins, and it was limited to the evaluation of vitamin B12 and folate. However, there are studies indicating the role of other vitamins in disease progression. The limitation being a short-term period of study with a smaller number of patients to reflect the effectiveness of supplementation in preventing the functional loss in glaucoma. So just to conclude, oral supplementation of neuroprotective vitamins can be helpful as an adjuvant along with the conventional anti-glaucoma medications in treatment of glaucoma. It might help us answer why patients who have actually achieved target IOP still show glaucoma progression, thereby indicating presence of non-IOP dependent factors. And long-term follow-up with oral supplementation of vitamin B12 and folate along with anti-glaucoma medications may stagger the structural loss in retinal nerve fiber layer and ganglions analysis and functional loss on visual field analysis. Thank you.
Thank you.
You have done, you have given the B12 and folate simultaneously.
Yes, ma'am. 1000 micrograms of vitamin B12 and 5 mg of folate once a day.
Because this vitamin B12, it acts by homocysteine
Yes, ma'am.
and it
Yes, ma'am.
produces apoptosis and kills the retinal cells if it is increased.
Ma'am, vitamin B12 is a water-soluble vitamin, so there
Yes.
are very less reports. In fact, I could not find a report of vitamin B12 toxicity that is happening in patients.
Actually, it depends on the doses, duration of the drug,
Yes.
and if it is, both are, acting differently. Folates are neuroprotective
Yes, ma'am.
in the full dose,
Yes, ma'am.
while the B12, if we are giving more, it causes the disastrous results.
Ma'am, the reason why we were not giving treatment dose, we were giving prophylactic dose, and the reason the study stopped at 6 months because we could not find any long-term data to tell as to what is the ideal duration of giving these vitamins.
So actually, this is non-specific.
Yes, ma'am. Ma'am, it was a new idea, a new concept, so we had to take maximum measures that we could control, and we had to, yes, give up on a few measures that were out of our control.
Did you find any increase in thickness of RNFL and GCC or
No,
just the
sir.
control?
No, sir. No,
Just
sir.
the
No
control.
increase in thickness in RNFL. Yes,
You
sir.
just detected no decrease in the thickness?
Yes, sir. We did document decrease, but the rate of decrease was more in the control group as compared to the intervention group, sir.
And results will be
Why do you
different.
expect a decrease in control group?
Sir, both
Because
the,
control group are non-glaucomatous.
No, sir. The control group was glaucomatous. They were on medical management with standard anti-glaucoma
Okay, got it,
medications.
got it.
The only difference was the control group was not given oral medications and the intervention group was given medications.
So,
Any variation in the this closed angle, open angle?
Ma'am, could be. The reason why, because the pathogenesis of both open angle and closed angle differs. Closed angle can cause sudden decrease in retinal nerve fiber and GCL analysis. The reason why we did not take it in the study, because the pathogenesis is different, it is difficult to compare both the mechanisms together in a single study.
Because folates are more beneficial in open angle.
Yes, ma'am. Ma'am, we could predict the probability progression of an open angle glaucoma. The reason why we prefer taking an open angle glaucoma as compared to angle closure, ma'am.
do you think you should have done the serum levels of these before starting the
Yes, ma'am, we
study?
did. Patients who did have hypervitaminosis of B12 or folate were excluded from the study. Patients with normal or lower normal was included, that too after informing them that this is this layer levels. Yes, ma'am.
Okay, thank you. Thank you, ma'am. And the next presenter, Dr. Nimrita Gyanchan. Yeah.
Good afternoon, everyone. I will be presenting the paper on outcomes of GAT combined with phacoemulsification in primary angle closure glaucoma. I have no financial disclosure. Primary angle closure glaucoma is considered more aggressive than primary open angle glaucoma as it has contributed higher rate of blindness. Although trabeculectomy is the standard surgical option, but it is often associated with various vision-threatening complications. Minimally invasive glaucoma surgery offers a broader, lesser invasive spectrum of surgical options for glaucoma management, and GAT has demonstrated safety and efficacy in POAG, but its role in PACT is limited. The persisting iridotrabecular contact and peripheral anterior synecdoche has provided good rationale for performing GAT in PACT. The purpose of a study was to evaluate the surgical outcomes of GAT combined with phacoemulsification in primary angle closure glaucoma. It was a prospective interventional study, included 84 eyes of 74 patients. Institutional ethics committee approval was taken and written and informed consent was taken. Patients with pre-treatment IOP greater than 21 mmHg on gonioscopy greater than 180 degree ITC contact and with glaucomatous disc damage were included, and the data were evaluated for 2 weeks, 1 month, 3 and 6 months. Outcome measures were evaluated in the terms of intraocular pressure, anti-glaucoma medication, best corrected visual acuity, surgical success, and any complications or interventions. Patients are refractory to maximum medical therapy showing the severity of visual field defect with significantly visual cataract and status post-peripheral PI were included, and patients with any history of prior ocular surgery or trauma, monoocular patients, acute angle closure glaucoma, neovascular glaucoma, and on anticoagulants were not included. So this is a video showing GAT combined with phaco was done in PECG group. Some patients had passed in the nasal angle, so goniosynostosis was performed with spatula. Then with MVR blade, 1 to 2 mm goniotomy incision was given. And then the blunted tip of pyoprolene suture was inserted into the Schlem's canal to complete 360-degree trabeculectomy. Coming to results, data were analyzed using Strata statistical software version 17.0 and an alpha level of 0.05 and 80% of power. The sample size required were 84 eyes. Success criteria were defined on complete success, which included criteria 1 and 2, IOP greater than 5 and less than or equal to 21 and 18, and more than 20% reduction and 25% reduction from baseline without any AGM. Qualified success were defined achieving success with AGM, and failure was defined inability to meet the criteria for success or requiring any additional glaucoma surgery. So these are the demographic characteristics of the patient with baseline IOP of 21.13 mmHg and baseline AGM 1.93. So the IOP significantly reduced from 21.13 to 12.65 with 34.9% of IOP reduction at the end of 6 months, and AGM significantly reduced from 1.93 to 0.17 at end of 6 months. BCVA improved at the last follow-up. The cumulative probability of success by criteria 1 and 2 was 86.9% and 73.8%. These are the KM plots by criteria 1 and 2. And 2 patients had microhyphema, out of which 1 required AC wash. Coming to discussions, various studies have shown favorable outcomes of GAT in POAG, but the literature is limited for the outcomes of GAT in PECG. But recently, the GAT has shown promising outcomes of GAT in PECG also, and data were comparable with other study group. So the limitation of a study, it was a shorter duration of follow-up. Visual fields were not analyzed on follow-up. Quantification of peripheral anterior synechiae was not done, and it included only Indian eyes. To conclude, GAT combined with phacoemulsification is safe and efficacious procedure in patients with primary angle closure glaucoma. It significantly reduces intraocular pressure and anti-glaucoma medication with good surgical success and rare vision-threatening complications. These are my references. Thank you.
What were the complications that you got when you are doing this procedure?
Sir,
for GAT, mostly.
Yes, sir. So microhyphemas are seen in almost all patients, but they are usually self-resolving by 1 week or 2 weeks. And major complications like macrohyphema are seen, but if they are non-resolving and causing decrease in vision, increase in IOP, we take them for AC wash.
Immediately on the table, what is the thing that you adopt in if it's a macro hemorrhage?
Sorry, sir?
Macro hemorrhage on table, what is the first step that you do?
So the most weapons for performing any minimally invasive glaucoma surgery is high density viscoelastic, cohesive viscoelastic. So whenever there is bleeding, we can use and the bleeding stops. Basically, we want to increase the eye pressure. So when the eye pressure is increased, there is stop of the reflex from the Schlem's canal, and then the bleeding stops, and then we can perform.
Yeah, generally they say inject a hyperviscoelastic and then take a coffee break.
So how can you include the patient in the according to the synechia or all angle closure glaucoma?
So patients with only acute angle closure glaucoma were excluded. Patients with synechia also on gonioscopy.
Synechia at 360 degree or at one quadrant only or through one?
So 360 degree were also included, but they didn't show good results. And if the patient had nasal synechia, we did GSL, goniosynostosis.
Because how can actually assess the all quadrant synucleitis? I don't know. It's very
But-
difficult.
So, but by performing GAT in PACG, it requires little more pressure to thread the suture because of the presence of synechiae.
No, actually you can show only the nasal side,
Yes.
your synucleitis, but in the superior side and other quadrant is,
So when the suture is not going, then we can thread in anti-clockwise direction. So
Okay.
we can do other side, 360-degree trabeculectomy, if it is not passing on the same side.
so you did the synucleitis in all quadrant?
No, sir. Only nasal quadrant, sir.
Only nasal quadrant.
Yes.
But when you actually release the suture, you can just tighten the suture, the all synechiae is not broken. Sometimes the iris is come out.
Sir,
It can
yes.
cause the iridodialysis and other things.
So actually, primary angular closure glaucoma have shown the results of iridodialysis, but it usually is seen where we give the main tunnel incision. But it is usually 1 to 2 clocar and it doesn't require any intervention.
It is very difficult. Okay. Thank you. So anybody is there? Dr. Bhavna? Ka? No.
Nobody.
Dr.
Is there any presenter here in this
Dr.
session?
Sahiti?
Dr. Sahiti?
Five are
No.
absent.
Vinod Kumar Singh?
50% attendance.
यही आया ना
We can have a group photo of all the speakers. Photographer to please stay.
Sir, के pencil करना ही है?
नहीं चलेगा
So we can have
300 faculty are absent
आज
आज रजिस्टर ही नहीं किए 800 invitations को 500 registrations so ऐसे ही रहेगा चल
we can just have a